Now, as you know, I'm not a pediatric surgeon, so I'm going to keep it very simple and very exam-based. Just sort of the warts and all things that I think that you need to know. But obviously, John, please feel free to add anything that I've missed out at all. So let's start with DDH. Well, I'd like to talk to you guys about the epidemiology and a little bit about the etiology. You need to know about the pathophysiology, about what really causes it. The most important thing is this third thing here. How do you assess a patient with DDH? And finally, management by different age groups. So let's start with epidemiology. DDH, first of all, is common. It occurs in about 1 in 1,000 patients in Caucasian groups have frank dislocation. About 1 in 100 have dysplasia. And actually in certain ethnic groups, like Native Americans, the incidence can increase to 188 out of 1,000 having a dislocation. So it's one of the most common newborn disorders that you see. So it's really important to know about it. And DDH is basically defined as abnormal development of the hip resulting from capsular laxity, a combination of both genetic and also mechanical factors. And the key buzzword for the exam is that it basically results in a spectrum of disease, which can start with just dysplasia to subluxation to frank dislocation or teratologic dislocation, which is essentially where someone has a frank dislocation in utero, which is irreducible. And it can be associated with genetic and neuromuscular conditions, this teratologic type, such as myelomeningocele, arthrogryposis, Larsen syndrome, or Ehlers-Danlos as well. So what causes DDH? What's the sort of pathophysiology behind it? There's believed to be initial instability, which causes dysplasia, abnormal development of the acetabulum. This dysplasia then causes subluxation of the femoral head, and gradually it will move towards dislocation. Over a long period of time, you get these chronic dislocations, and secondary barriers will then develop to preventing reduction, which can be divided into both extrinsic, so those are muscular barriers, things like psoas tendon tightness, adductor tightness, hamstring tightness, or intrinsic barriers to reduction. And we'll come on to those shortly. As a result of this chronic dislocation, you get anatomical changes over time. So the femoral head becomes flatter. You get a more anteverted appearance of both the femur and the acetabulum. You also get increased obliquity and decreased concavity of the acetabular roof. And you get thickening of the medial acetabular wall, okay? So the typical deficiency that you get is anterior or anterolateral acetabular deficiency, okay? Whereas in a neuromuscular type like cerebral palsy, you get posterior-superior acetabular deficiency, okay? So I think this is the most important part of the talk today, and also for your life as an orthopedic surgeon. How do you assess these patients? So assessment starts immediately at birth. Every baby that's born will get an assessment of their hips, will get a screening within the first 6 weeks by the health visitor as well. And then those babies which are at risk or have an abnormal examination are referred to the baby ultrasound clinic, which normally happens about 6 weeks. The key point is it's not universal screening. Not everybody gets sent to the baby ultrasound clinic. And within this baby ultrasound clinic, my favorite phrase, you get a triple assessment consisting of history, examination, and radiological assessment. So from a history point of view, you're looking for risk factors. And I break these down into the 5 Fs. So are they female? Are they firstborn? Do they have a problem with fluid, oligohydramnios, fetal malpositioning, breech, and also family history? So these are the kind of things that I'm asking for in a pediatric clinic assessment. On examination, I'm looking for asymmetry between the two sides. So I can test that by looking for gluteal skin creases. And you can see here that there's more creases on the left compared to the right. So that's suggesting that maybe there's asymmetry. You can also look for asymmetry in terms of leg lengths, and we do something called the GALEAZZI test, which can be looked to see for asymmetry of the femurs and also asymmetry from the tibia. So in the coronal plane, you're looking for difference in the heights of the femurs In the sagittal plane, you're looking for differences in the heights of the tibia. So that's GALEAZZI test. Again, it's evidence of asymmetry. You can do Barlow's ORTOLANIS. So the first thing you're working out is this asymmetrical? Fine. The next thing is it dislocated or dislocatable? And Barlow's and ORTOLANIS will tell you that. So to do these tests, you need a relaxed baby with a firm surface, and it's got to be a gentle examination. So Barlow's will basically dislocate a dislocatable hip by adducting the hip and depressing the femur, which is in a flexed position. It's at about 90 degrees of flexion, okay? And you get this clunking sound as basically you compress the hip down. And that tells you that it's dislocatable. ORTOLANIS, on the other hand, will reduce a dislocated hip. So what you're doing here is you're abducting the hips and you're also elevating a flexed femur. You're seeing, can I reduce this or not? So at the end of Barlow's and ORTOLANIS, you should be able to follow this flow diagram here, okay? So basically, this is a flow diagram that I've made. Is it dislocated? Yes. Is it reducible? Yes. Then it's ORTOLANIS positive. If it's not reducible, okay, oh, it seems to have frozen on me. So what I would say basically is it distal? I'm just going to end the show there to see if I can see that on here. So the first thing I want to say is the hip dislocated? If it is, I want to try and reduce it. If it's reducible, it's ORTOLANIS positive, okay? If it's not reducible, it's ORTOLANIS negative, okay? The next thing I would ask is it dislocatable? So it's not dislocated, but is it dislocatable? Yes, it's Barlow's positive, okay? If it's not dislocatable, is it subluxable, okay? And if it is of those, then it's what we call Barlow's suggestive. So at the end of this, you should be able to divide them into one of four groups. Either it's in joint and it's stable, or it's in joint but dislocatable, called Barlow's positive. It's dislocated but reducible, which is ORTOLANIS positive, and it's dislocated and irreducible, okay? The other thing you can do is you can examine children late on. So basically, do they have excessive lordosis? Do they have a Trendelenburg gait as well? These are children who typically present late. They may also have a waddling gait. They may have unilateral long leg flexion or tiptoeing on the short leg, indicating that there's a leg length discrepancy as well. So those are all things that I do as part of my examination. Finally, I basically do a radiological assessment, and that's using an ultrasound. And the reason why we don't use X-ray before about 4 to 6 months is because the ossific nucleus doesn't become apparent before then. So actually ultrasound is the best way of assessing it. And the way to interpret a baby ultrasound is, I think of this guy here, the Mercedes-Benz, okay? And if you turn a Mercedes-Benz on its side, you get this thing here. So you first of all have the ilium or the backbone, then you have basically the cartilaginous roof, and then you've got the bony roof, okay? So the angle between the ilium backbone and the cartilaginous roof gives you the beta angle. The angle between the ilium and the bony roof gives you the alpha angle. And you can see here that the beta angle has increased and the alpha angle has decreased, and therefore you've got a femoral head which is subluxed. Okay, so I'm going to explain that to you just a little bit more. And this diagram will sort of show you what I mean. So you've got the ilium or backbone, which forms a labrum or soft tissue roof, and a bony or acetabular roof, okay? Then you have angles forming between those. So between the baseline, the ilium, and the labrum, you have the beta angle, and between the baseline and the acetabular roof, the bony roof, you have the alpha angle, okay? So what's the relevance of this? Well, I mentioned something called graph classification. Now, when I do a baby ultrasound, you do it with the hip static, which is the graph classification, and you do it with the hip on the move, okay? So do you need to know graph classification in any detail at all? Absolutely not. All I would learn that in DDH, basically the alpha angle goes down and the beta angle goes up. And that's pretty much all you need to learn, okay? The alpha angle should normally be more than 60. The beta angle should be less than 55, okay? And I wouldn't learn any more for the exam than that. So I told you guys that, okay, fine. You can use the baby ultrasound within the first 6 weeks. What do you do at about 4 to 6 months? Well, the next form of investigation is to do x-rays, and you're looking for 4 things on the x-ray. Okay, so the first thing you look at is the ossific nucleus. It's typically small in a patient with DDH. You can draw a line through the triradiate cartilage, which is called Hilgenreiner's line. You can draw a line basically perpendicular to the triradiate cartilage through the lateral part of the acetabulum, the upper lateral part, which is called Perkin's line. And these two together will form quadrants. And typically a normal head should sit in the inferomedial quadrant, which this one is here on the right. If it's subluxed, it sits in the inferolateral quadrant. If it's frankly dislocated, it sits in the superolateral quadrant, which this one on the left does. You also look at the Shenton's line. You can see a nice complete Shenton's line on the right. You can see a broken Shenton's line on the left. And then finally, you can do what's called the acetabular index, which is an angle between Hilgenreiner's line through the triradiate cartilage and also a line along the lateral border of the acetabulum, okay? And the acetabular index should be less than 25 degrees. It gets bigger in patients with DDH. Now that's used to assess the younger patient, but in the older child, there's another thing that you can look for as well. And it's basically called the lateral center edge angle of Weiberg, okay? And what you do here is you take the center of the femoral head, you take a vertical line, and you basically form a line from the center of the femoral head to the lateral border of the acetabulum. And it's the angle between those two. It should normally be less than 25 degrees. That should say more than 25 degrees is equal to acetabular dysplasia. So that's something we'll use in children over the age of 5 or young adults with dysplasia. Okay, so I'm now going to move on to the crux of the talk. I've talked to you guys about how, you know, what causes DDH, what some of the risk factors are, and how you'd assess them by a triple assessment: history, examination, and radiology, and how that varies depending on the age of the patient. But in the exam, they will often ask you about how do you manage DDH. And I always break it down into starting off with the goals and then the management of by age. So my goals of treatment in DDH are 4-fold. I want to have a stable, concentrically reduced hip, which allows normal acetabular development to prevent basically degenerative joint disease, okay? And the way that I achieve that depends upon the age of the patient. So I'm going to break it down into these 4 timelines. Now, I must reiterate that there is variation between pediatric center. I know certain people do things earlier, but for the exam, I would just learn these 4 main categories and stick to them. Less than 6 months, 6 to 12 months, at 12 months, and 18 months to the older child. I think it's the easiest way to break it down. Okay, so less than 6 months, what are you going to do? You get your baby to the baby ultrasound clinic and you find that actually they're Barlow's positive, but they're also ORTOLANIS positive. And there's an increased beta angle and a reduced alpha angle when I do my baby ultrasound. What am I going to do? So less than 6 months, I'm going to ask a question. Sam, could I get you to unmute for me, please?
Hello.
Yeah, so Sam, what would you do? This kid's come to your baby ultrasound clinic. They're 6 months old, and you found that actually the hip is dislocatable, but you can reduce it. And also they've got an increased beta angle and a reduced alpha angle. What are you going to do?
Yes, they've got evidence of dysplasia and an unstable hip. So place them into a Pavlik harness, scan them within the harness to see if they remain reduced.
Okay, so how does the Pavlik harness work?
So through abduction and flexion of the hip, it holds it, or attempts to hold it in a concentric position so the acetabulum can deepen and reduce the index over time.
Okay, so tell me about this, the 4 straps of the Pavlik harness. What are the 4 straps?
Pass.
Okay, no worries. And is it a static or a dynamic splint? I've kind of given it away a bit. But it's,
yeah, dynamic splint.
Dynamic splint. So how does it actually work?
Well, the straps hold the hip within a certain sort of range of movement in that sort of abducted position. Yeah, but allow some movement within that sort of those safe zones.
Okay, and then All right, I'll just clarify that for you in a second. But how long would you use a Pavlik harness up till? What's the age limit?
I think it's up to 6 months.
Why? What happens at 6 months?
I'm not sure.
Okay, so in the normal milestones of a child, the child sits up at 6 months. Right. So the key point is a Pavlik harness relies upon the child kicking out to effectively reduce their own hip. So at 6 months, because they sit up, they're not going to kick out anymore. And that's why you're using it up to that time point. Now, as we said, it's a dynamic splint. It's called a flexion abduction orthosis, and it is made up of 4 straps. So there's a shoulder strap, which can occasionally cause brachial plexus problems. There's a chest strap, which is used to size the Pavlik harness, which can cause skin problems. And then there's an anterior strap, which flexes the hip up. Now, the key point is the anterior strap can cause a femoral nerve palsy. So when we assess these children clinically, we check that they're kicking out, because that will show us that knee extension is working, and therefore the femoral nerve is working. And the posterior strap is the abduction strap. But the problem is you have to keep them in a safe zone of motion. So if you abduct too much, you're basically going to cause AVN. Whereas if you adduct too much, you're going to cause dislocation. So what we do is we take them to the extreme of abduction and then take them back about 15 degrees. And then we take them to adduction until they're about to come out, and then take them back 15 degrees. And that is Ramsey's safe zone. And our goals of treatment is we want Ramsey's safe zone to effectively be as big as possible. If it's quite a small safe zone, it probably means that it's an unstable hip and it's not going to stay in joint. Okay. Now, the other thing is, Sam, I'm just going to stay with you a second. So you've done your Pavlik harness. You mentioned to me that you bring the child back and you do repeat ultrasounds to check it's in joint. And that's absolutely correct. Now, some centers will do it every couple of weeks. Some will do it a little bit less regularly, about 6 weeks. But you normally keep them in for about 3 months until the ossific nucleus has formed. What are the prerequisites to put them in a Pavlik harness? What does it require?
So it needs a reducible hip.
Yep, it's got to be reducible, number one. What else?
From what you said, a sort of functioning neurologically normal child, because that's how it
excellent, because it's got to basically
functions.
Out. So the neurology has got to be okay. And what else? Third thing.
So compliant sort of patient and parents.
So kids not really going to be that able to.
Yeah.
But the third thing is basically the joint has got to be supple, so you can't have arthrogryposis. So what would you do if you put them in, you've got them really nicely reduced, let's say it's 6 weeks, and you bring them back at 8 weeks and the hip is now out of joint? What would you do then?
So you would try again. So usually try and reposition, scan again to see if it is reducible, and then attempt the same, but with a shorter follow-up period then to see if they have maintained a reduction.
Okay, so if it's come out, it's probably not going to stay in. So my answer for the exam would be effectively, I send the baby back to the parents, enjoy the baby, and bring them back for a semi-elective procedure at about 6 months. Okay, so that would be my answer for the exam. Okay. So we now move on to the 6 months. I should say 6 months rather than 6 to 12, okay? And what you do here is at 6 months, this time you'll assess them with a X-ray. You do an EUA, an arthrogram, and a closed reduction. And I should also say that you can add an adductor tenotomy there at the same time. And essentially what you're doing with the arthrogram is you're assessing this thing here called the medial pooling of dye, okay? If you've got lots of medial pooling of dye, it means that the hip is quite lateralized. It's a bad sign, okay? So what we say is 7 millimeters is kind of the cutoff that they quote for you in the MCQs. We say less than 3 millimeters is good, 5 to 6 is fair, greater than 6 to 7 is poor, okay? And it indicates quite significant lateralization. We also talk about blocks to reduction, and I break these down into intrinsic and extrinsic, okay? So extrinsic would be muscles, tight psoas, tight rectus femoris, tight adductors, tight hamstrings. Whereas intrinsic, you can kind of work from outside to in. So it can be an hourglass capsule constriction. It can be inverted labrum called limbus. It can be the transverse acetabular ligament, the ligamentum teres, and the pulvinar fat. And that's a list you've just got to be able to reel off in the exam. guys. So you just need to know those blocks for reduction in the exam. Okay, good. So let's say you've done the EUA, you've done the arthrogram, and you've basically done a closed reduction adductor stenotomy. What are you going to do next? Well, what I would do is I would put them into a hip spiker, and I would send them straight from the operating theatre to CT to make sure that it's in joint. I will then bring them back to theatre in 6 weeks for a change of spiker and re-CT them, and I keep that regimen going for about 3 months. Okay, so what happens next? You bring them back at let's say you do this at 6 months, and you bring them back 6 weeks later, and it's out of joint when you do your check CT. Or you send them straight from theatre to CT, and it's out of joint. What are you going to do now? Sheba, I'll come on to you for that.
So if the hip's dislocated after a closed reduction on the post-operative CT scan, I would abandon, and I would plan for an open reduction at over 12 months old.
So if they're 7 months, let's say they've done the operation at 6 or 7 months, would you do the open reduction at that point?
No, they're too small.
Okay. Would you keep them in a hip spiker?
No.
No. Good. So that's the pitfall guys often fall into, is don't say I'd put them back in a hip spiker. It's useless. Effectively, you bring them back for a semi-elective procedure at 12 months, which is an open reduction. Now, there is an area of controversy here, and I was actually talking to John about this earlier. So there is this thing called the Ludlow procedure, or a medial approach, and they often quote it in the MCQs. It can be done a bit earlier at 9 months, and that's where you go between pectineus and adductor longus and brevis. Okay, but the exposure is not as great. There's an increased risk of AVN, and it's often not done in British centres. It's something that's commonly done in places like Australia. So I wouldn't quote it for the exam. I would just know it as an option if they asked you about it, or in the MCQs. So the one to quote in the exam and understand is the Smith-Peterson, which is basically an anterior approach. It works on an internervous plane between the femoral and superior gluteal nerves. And that's the one to quote in the exam. And it's exactly the same regimen. You put them in a spiker, you send them from theatre into a CT, you check it's in joint, you bring them back to theatre in 6 weeks for a change of spiker in theatre, and you're basically keeping them in this for 3 months. Again, this time you do this open reduction, they're 1 year old, and you find that actually when you've sent them to CT, it's out of joint. What are you going to do now? Darren, can I get you to answer this one? Darren Ebrio.
Hello.
Yes.
You send them for CT and it's out of joint.
Out of joint. It's 1 year. You've done your open reduction.
If you've done an open reduction and it won't stay in, then you've got to attend to the factors that are precluding it. So, assuming that you've
removed all your blocks to reduction, you've done your adductor tenotomy, you've taken out your inverted limbus, your TAL, whatever, all of those blocks, you've got those out the way, and it still feels unstable or whatever.
Then it's a containment issue. So you can either do a soft tissue procedure, so like a capsular resting or reefing to close down the volume of the capsule, or you've got to do a bony procedure, depending on whether you have, for example, a very high neck shaft angle, so you need to bring the head down into the acetabulum by doing a varus derotation or shortening.
Okay, yeah, so the correct answer I want you to get at really is about osteotomies. Basically, you're looking at bony procedures, which, as Darren said very rightly, can be at the level of the femur or can be at the level of the acetabulum. Now, guys, don't shoot me for this because, again, this is an area of controversy. The age at which people do osteotomies does vary between centres. Some would talk about doing a femoral osteotomy as early as 12 to 14 months. Most people would say you don't do an acetabular osteotomy before 18 months. For the exam, I went with 18 months because that's what I'd seen in my centre for both femoral and acetabular. But again, as long as you have a justification, this is what I've seen in my centre, that is completely reasonable. You can read tons of papers and they all argue different dates. So in terms of osteotomies, what they're looking for, it's not so much the date, it's the decision making. So femoral, when would I choose a femoral one? And the one that you normally do is either a shortening or a varus derotation osteotomy. And it's basically, if I think that there's a problem with excessive amounts of abduction or adduction, or maybe when I get them in and I do my RAMSEY safe zone, I find that it's an excessively small range to stabilize that hip, or a hip that's been subluxed or dislocated proximally for a long period of time. Maybe there's a pseudo-acetabulum and I need to bring that femur down by doing some sort of shortening osteotomy. That's what I'm thinking about as my decision making for doing a femoral osteotomy. For an acetabular osteotomy, maybe if it's something like the shape of it, rotational problem, and it's a containment issue, then I'd be thinking more about doing an acetabular osteotomy. And these can be broken down into reconstruction or salvage osteotomies, okay? And reconstruction can be further broken down into volume reducing, which basically means that the acetabulum is the wrong shape, or redirectional, where it's the right shape but in the wrong place, okay? That's how I sort of roughly think of things in my head. And my choice of osteotomy, I look at a number of different factors. I look at the age of the patient. Is the triradiate cartilage open? So the triradiate cartilage typically closes at 12 for girls, 14 for boys. And remember that the symphysis pubis is not as mobile in older children. Is there any deficiency? And in particular, is the posterior wall intact? And are there any underlying neuromuscular conditions? Those are the kind of factors that I'm thinking of in my head in terms of my choice of osteotomy. And guys, getting up to there is probably enough in the exam to get you a high 7 or even an 8, okay? The key thing is stay generic on your osteotomies. You don't need to name the osteotomy. The next few slides are for those of you who are going to be going for the gold medal. And so I just wanted to very quickly mention about these osteotomies so you understand the difference between them, okay? So as I said, femoral osteotomies, your options would be to do a derotation osteotomy. So for example, someone who's got quite a valgus neck, or maybe excessive amounts of anteversion, you're doing a varus osteotomy and you're trying to increase coverage of that femoral head so that basically the acetabulum can develop in the correct place. There's a femur that's sitting very proximally. It's formed a pseudoacetabulum. You need to bring that down. It's a shortening osteotomy, and typically we shorten them by about 2.5 centimeters, okay? It's basically the distance from the inferior part of the head to the acetabulum inferior border. That's what you're trying to bring them down by, okay? And you fix that with a plate and screws, okay? So with acetabular, I broke it down into volume reducing and redirectional. So redirectional, first of all, what are your prerequisites? Well, you've got to have a hip that's congruent, it's got to be correctable, and you've got to have a reasonably good range of motion as well. And you can do it by age. So my decision making would be in the younger child, 18 months, 2 years, etc. I'd be looking at something like a Salter, okay? In sort of the 6 years to teenage group, the older child, I'd be looking at a triple osteotomy, 3 cuts, and that can either be a Tonis or a steel. And then teenage to adulthood, you're looking at a periacetabular osteotomy or a Gans, okay? So I'm going to very quickly just mention some of those to you, okay? So Salter is an example of a redirectional osteotomy, and you are making a single cut from the ilium to the sciatic notch. And basically, you're rotating the hip around an open triradiate cartilage. So it has to be an open triradiate cartilage, and the symphysis pubis has to be mobile. So it's in a younger child, okay? Because the acetabulum is hinging through that symphysis pubis. Now, because you are effectively making a cut from the ilium to the sciatic notch, it's an unstable osteotomy, so it does require some kind of fixation as well. And it's basically improving the anterolateral coverage of the head. I'll just show you that one more time. So single cut, ilium to sciatic notch, put some graft in, fix it, and you're improving coverage of that head, the anterolateral part of the head. Okay? The other one is a triple, and a triple basically is in a slightly older child. So again, the triradiate cartilage is open, but this time the symphysis pubis is not as mobile, so you can't hinge to the symphysis pubis. So you have to effectively create your own hinge, which is why, in addition to the Salter osteotomy, you make these 2 extra cuts, okay? And the only difference between a steel and a Tonis is basically this cut through the ischium is more curved in a Tonis and slightly less curved in a steel. So it just gives you a greater amount of correction. I wouldn't learn any more than that for the exam. That is more than enough, okay? We then move on to the volume reducing osteotomies. Again, these are a form of reconstruction, and it has to be a congruent hip, and it has to have good hip movement as well, okay? And the ones you need to know, or they may mention, typically in the MCQs, are the Pemberton and the Dagger, okay? So with the Pemberton, it's a type of volume reducing osteotomy. Sorry guys, can you just mute your mics, please? Okay, good. So the Pemberton, a volume reducing osteotomy. What's happening here, I'll just show you this. So with the Pemberton, basically the osteotomy starts about 10 to 15 centimeters above the anterior superior iliac spine, and it proceeds to end at the level of the ilioischial limb of the triradiate cartilage. So basically it goes halfway between the sciatic notch and the posterior acetabular rim. Now the key point is you don't quite go to the sciatic notch. You put a graft in, you bring the whole thing down, so you're doing a volume reducing thing. And because you don't go through the sciatic notch, you don't need internal fixation. So that's the reason. It's a relatively stable osteotomy, and it gives you good correction as well, okay? The Dagger is used for those patients who have neuromuscular conditions, okay? So this time you're going from the acetabular roof to the triradiate cartilage. But again, it's incomplete. You don't quite go all the way to the sciatic notch. You bring it down and you essentially put some graft in there. All you need to know about this is it's stable because you don't enter the sciatic notch, so you don't need internal fixation, and you use it in patients who have neuromuscular conditions. So it's basically the osteotomy of choice in cerebral palsy. You won't get asked anything more than that for the exam, okay? So those are your reconstruction osteotomies. We then move on to salvage. And this time, these are hips which are incongruent and uncontained, okay? And the two types you might hear of are the shelf and the CHIARI, okay? So shelf is typically the older child more than 8 when they have inadequate coverage, and the CHIARI is where there's inadequate coverage and you can't get a concentric reduction. The key point is healing occurs here by fibrous metaplasia. So that's the buzzword to use for the exam, okay? So I'll just show you what a shelf looks like here. Again, these are just my animations that I've done. But basically, you've got an uncovered head. You put some bony graft in, essentially, covering the head, okay? That's as simple as it gets, all right? I'm sure it's more complex than that, but just think you're adding some sort of shelf to improve head coverage, okay? CHIARI is slightly different. So with CHIARI, you're making a cut, femoral head's uncovered, you're bringing the whole thing, shifting it medially, and the cut goes all the way from the sciatic notch to the anterior superior spine. It's through the sciatic notch, it's unstable, so you need internal fixation, but now you can see that the head is covered. So again, it's a salvage procedure because you've got some sort of bony graft or bony part of the island which is now covering the head. So you're expecting it to still sublux, but essentially you're increasing the amount of coverage, which is why it's a salvage procedure. Okay, so in summary, guys, that's pretty much in a nutshell what you need to know for DDH for the exam. You need to understand about the risk factors. Remember the 5 Fs. Remember about the pathophysiology. It's a mixture of both genetic and environmental factors. One thing I didn't mention is DDH was thought to be a packaging disorder. It was thought to be because of less space in utero. And the list of packaging disorders is things like torticollis, metatarsus adductus, calcaneus valgus. But it's now been shown that actually DDH, similar to CTEV, is actually probably due to polygenic inheritance, or there is certainly a genetic component there. We see it more commonly in twins. We see it in certain genetic races as well. So it probably isn't a strict packaging disorders, although there are certainly some associations there. You need to know how to assess the DDH patient. So remember my triple assessment: history, examination, radiology, okay? In the younger kid, less than 6 months, you're thinking baby ultrasound, not universal screening. 6 months onwards, you're thinking basically X-ray. Management of DDH by age. And remember, the key point is of the osteotomy question, don't name the osteotomy too quickly, okay? It's all about using generic terms: reconstruction, salvage, volume reducing, and redirectional, okay? Thanks, guys.